So yeah, we're going to be going over different vertebral augmentation and kyphoplasty techniques. I'm here with the, world famous Dr. Douglas Beall, who, pretty much is the godfather, I believe is, godfather of vertebral augmentation and kyphoplasty, who's, developed techniques that really revolutionized the field of vertebral augmentation and kyphoplasty. So, we're kind of having a dual piano here, technique here and scenario here. So bear with us, but I think we're going to have a lot to go over.
So what we'll do here is we're going to come down and get in position. So we're going to go over the star ablation device, Stryker spine jack. We'll have the Medtronic Kyphon, and we'll also go through some of the different offerings from Merit. But I'm going to show you the transpedicular approach to a spine jack, and then we'll transition over to Dr. David, but on this one, as I do the other side. So this is a transpedicular approach. We have, go ahead and come back. I might just I'll do L3 here. That's well suited. So it's a standard transpedicular approach, and we will go more on the 9 o'clock and 3 o'clock positions on the pedicle rather than the traditional 10 and 2 respectively, because that's, we want to come in very flat on the vertebral body. So we'll start area like this, and we'll do a transpedicular approach. And remember, never cross the medial wall of the pedicle. Let's go lateral, please, until we're in the posterior wall of the vertebral body. And once we're in the posterior wall, we transition over from the access needle, which I use a bevel needle. They also have a diamond tip needle, diamond tip point. So we're in the posterior portion of the vertebral body. And I'll do the manual wig wag here. Try to sharpen up the end plates a little bit. There we go. And so we'll take it to the anterior portion of the vertebral body. And we'll medialize it a reasonable amount. Change through to the K-wire, and we'll take the needle out after that, leaving the K-wire behind. And just windshield wiper this out. Don't lose access, don't pull the K-wire out. And good position there. We'll go ahead and come with the reamer, and this looks like a drill, but it's a reamer. The sides of it are cutting. It's fluted, so this has directional capability because the sides of what looks like the drill they cut forward and they cut to the side, so this has directional capability. And so with this, let's go back around to AP so we can see the trajectory of that. With the K-wire, we want this to be angled as a V in front, so the elliptical lifting force will happen around the course of the spine jacks that are placed like this to the front part of the vertebral body. So we'll take the picture and we will see right toward the midline, and that's about perfect, I think. So we'll go back, transition back to the lateral approach, and I'm going to advance this in to the anterior portion of the vertebral body within about 3 to 5 millimeters of the anterior wall.
Can you go to AP?
And we want to make sure that your K-wire doesn't run on you. Maintain the appropriate trajectory. And we'll take the reamer all the way out to the front part of the vertebral body. Just like that. And we have the 5-0. Take the inside of the reamer, leaving the working channel behind. And I'm going to Regan will go ahead and mix that up. You can use an acrylic plug or you can use a template. And we have the acrylic plug here that we'll put in the anterior portion of the vertebral body. And we have a plug in the distal tip there. We'll put it all the way out to mimic the pathway, right in the pathway of our reamer. We're going to mix the cement, and as we mix, and as I do the other side, we'll transition over for Dr. David.
Excellent. Well, thank you very much. Nice approach there, Doug. we're looking at, this is more of a uniperpendicular approach. We're going through the pedicle and coming across the pedicle while we're making sure we're not crossing the medial pedicle line there, though, as we come in and before we get into the vertebral body. So as you see at the L2, L3 level here, let's go a little bit of cranial tilt. And live. As you were ending approximately 1/3 in depth into the vertebral body, as you see on the AP at the L3 level. Oh, okay. Picture there. And lock it there for me. And, okay. We're ending at, more centralized endpoint for the needle. And at this point, we're using the actual Medtronic device system. At this point, we're using the drill to drill it out. Picture there. And we look under, of course, a more lateral view. Okay, picture there. And then we're using the Kyphon Assist, and what the Kyphon Assist for Medtronic, the device itself, what it enables one to do is stay away from the actual end plate fracture. In this case, we don't have any really end plate fractures, but if we wanted to provide some direction to the actual device itself, there's quite a unique technique that can be used to make sure that we are making sure the balloon is providing some direction to the area and away from end plates. Picture. And to segue, at this point, well, the actual drill actually has some color coding. Well, why is that? Well, the Medtronic device actually has some advantages of being able to be used for tumor ablation as well. I think the OsteoCool device system provides a lot of good therapies to the patients who have tumor metastases to the vertebral bodies. And if we can have a picture at our piece of chicken there. I'm not sure if that's visualized on the area there. But an AP view, we have a view of some chicken being pretty much ablated with the OsteoCool device using a Peripedicular approach. And as you can see, well, the advantage of OsteoCool itself, the tip itself is cooled with distilled water running through the distal end of that needle, or probe in this case. And what it enables one to do is make sure that there's no significant charring occurring around that probe. And that enables the ablation zone to be larger and a larger heat zone in that area, okay? So, and pan back to the actual patient again, or the cadaver here. If you look at the actual device itself, we change over now. After we do the ablation, then we would remove the actual drill or a probe in this case, if it was an ablation, and move forward with kind of coring out the actual vertebral body, was using some techniques of, in this case, a curette that Medtronic has. Picture there, picture there, picture there. And you're able to core out, picture there, some of the vertebral body there, picture. Of course, it'd be quite soft and a little bit softer than this, but picture. And picture. And let's go to core out a little more. Picture there. Picture. Picture. Picture there. Picture. And picture. Picture. And if you want to go back to AP view, so you core it out and make some room for the actual balloon. And their balloons go up to 750 cc's of PSI, sorry. Picture there. And so you can further core it out in more AP view, picture. Picture. Picture there. Do a little deeper with the actual Kyphon assist picture there. And you see it's almost like a beveled opening that you can advance. And mallet, please. Oh, there it is. A little deeper picture. But provide some direction to it. You want to make sure the opening is going away from the actual end plate, which, yeah. A lot of times you're going to make sure that you're keeping the balloon away from the end plate itself, picture. So you're not providing even more leakage from occurring. Picture there. Okay. Okay. Picture. Thank you. Picture there. Picture. Picture. Go a little bit deeper there. Picture. Picture. And core out a little more. Picture. We're using a 20 millimeter balloon here to get into the area. Picture there. Picture. I got to core it out a little more. Picture there. Picture. 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 Let's try and get a little more room for that balloon to, sorry, that balloon to enter. Picture. Picture there. And let's try the balloon again. Picture there. A lot better. Picture. Back it up a little bit. Picture. And we'll inflate that balloon. Live. Every 2 seconds. And you see, with that Kyphon assist, you can veer that balloon away from the actual end plate itself and advance a little bit more. That cannula. Picture there. Picture there.
David prepares the balloon for the cement. I'll go ahead and, if we can switch back over to the spine jack, we have our cement mixed and ready to go. And we will see the spine jack deployed in the AP. We'd switch the floor images back over. And they're right in apposition with each other. And let's go lateral. And we're going to deploy these. And the deployment is done by the butterfly handle. And each one of these they deploy parallel to the handle. So they deploy, wherever you have the handle pointed, they will deploy parallel to this. And we'll go ahead and watch this as it comes up. So deployment here, 2 or 3 turns on the butterfly handle, one side, 2 or 3 turns on the other side. Spine jack will pop up like a scissor jack, which is exactly what it is. And we'll full expansion, 2 or 3 turns, 2 or 3 turns, and we can see it lifts in a V shaped with the anterior portions near or even touching one another, and that creates an elliptical lifting force. And so we will advance this,
save that,
and we'll deploy. There's 13 turns all the way to complete deployment, and it has a hard stop at the very end. So almost to complete deployment, hard stop, a couple of back turns to take the tension off. And then once we have complete deployment, here's what it looks like on fluoroscopy. A couple of back turns, we'll counterclockwise on the colored knob, and this is 10 turns to get it all the way out. And you pull it back, just take your hand completely away and pop the top off of these.
There you go.
Resist the urge to hold the handle as you might dislodge the working channel from the implant itself. So we'll take this out, and we now have bone fillers ready to go. So we look at the complete deployment, very nice.
Doug, could you show that on AP?
Sure can. Let's come back around to AP and take a shot before we inject any of the cement.
Good.
And the goal is to have these very close. It creates the natural lifting, elliptical lifting force. So here's what it looks like on the AP, either side of midline, and
just go AP.
Nice full expansion of the 5mm spine jacks. Let's go lateral. These will raise up to 17 millimeters from top to bottom. And we'll go ahead and inject the cement. It's already nice and very, very thick. So it expands and goes along the pathway that's created by the spine jack. And it fills that pathway, and it will tend to join each other from side to side in a horseshoe shape. So we have each one of these is almost 2 cc's of cement. So we'll put in this, and we'll put in 2 full bone filler tubes, and we'll put in part of the other one. You'll find that you use about 2/3 as much cement with spine jack as a traditional balloon kyphoplasty. So put 1.5 tubes each side, and that looks pretty darn good. Let's take an AP shot, see how we're doing. And we want to make sure that the cement will touch each other from side to side. That way, especially in patients with exceedingly poor bone quality, the only thing that can happen is incident level refracture, and that's perfect. So bone cement joins from side to side, and we have really nice reduction, nice placement of the spine jack, and we'll have a little bit of bone tamping to make sure the cement doesn't back out on us. As soon as you hear the click, you know the cement is in there. And then traditionally, I usually recommend that you put K-wire through this, and you take a twist on this and pull. Other side, K-wire through, twist to shear the cement off and pull. And here we get a final view there. Let's take a final lateral view. Shape of things to come. Spine jacks with intradiscal hydrogel on one film. Future treatments of interventional spine. And here's final lateral view. Very nice.
Excellent, excellent. Well, let's pan back over to this cadaver. As you see, we have the Kyphon assist with the balloon. And this inflated, we actually used a smaller balloon at 15 millimeters. And you can see the Kyphon assist helps to make sure we're veering away from areas that, where there's end plate fractures, which we see all the time, inferior, superior end plate fractures, and keeping away from those areas so we don't have undue spread of cement into the disc. A nice fill of the balloon there, and over on the APV there. Can you show the lateral as well, guys? Oh, let's go to the lateral then, and see the spread of the cement, spread of the inflated balloon. that area. Picture there. Great, that's great. You see that over there, Neil, Ramo?
The X-ray needs to go a little bit more toward the abdomen.
Okay.
You're up on the
Lower.
dorsal skin. There you go.
Perfect, thank you.
Yeah, that shows beautifully.
And yeah, you can help keep you away from that end plate nicely. If we could deflate that balloon quickly, and then we'll employ some cement here quickly here, and then we'll kind of show some of the advantage of the Merrick system quickly. Picture there. Picture there. Picture there. Picture there. Yeah. Picture. And picture.
And Glenn, if you could describe a bit of the hydraulic aspect of the
Picture.
injection device.
Well, this is a hand pump and for the Medtronic device. Picture itself. For the actual Merit, they have actually an RF generator that actually helps to employ that and provide heat to the cement as it's being employed into the patient. Picture there. Picture there. And live. And making sure that the cement is at optimum thickness is obviously quite important. Making sure you're delivering on a lateral view. Further than that. And back to 8P, please. I want to see the spread across. Awesome. Okay.
That shows well.
Doug, you want to go over some of the advantages of some of the power, the actual power curve, but actually the ablation device as well?
Sure will. So we'll talk a little bit about spine star ablation device. And we have the needle here, the access needle. It's beveled. And through this, we have spine star ablation device. Thank you. Okay, so bevel needle. Take a shot of this, the blue hub, and then we have spine star ablation device. This directional indicator, and it's when you twist the gray knob, this is the direction in which it will rotate. It will go bend toward that direction. This is the same direction as the bevel of the needle. The bevel sits right here with the angle with the distal tip of my finger. This will accentuate the steering capability of this needle. As we turn the knob, it will go this direction. And this white knob advances the ablation. This is a bipolar ablation. And turning it right will advance the bipolar out, needle out. So you put it in place, advance it out, and this is how it works. And I find it works really well in conjunction with my favorite tip is the single bevel needle that provides directional capability. And this is designed to be used in a coaxial type fashion. So let's bring it back into place. And let's place this and let's do some ablation. Directional capability allows you to get throughout the vertebral body. So we'll do this at L4 level. So you notice I'm starting the approach is a little bit steeper than the approach previously because this has directional capability. You can easily reach the opposite side of the vertebral body. So I don't want to make it too much of a midline approach. So come down, good transperpendicular approach, fairly steep. Let's go lateral. And then we'll enter with the spine star ablation device to reach all portions of the vertebral body that we need to be able to successfully ablate the tumor. So right there, right at the posterior wall, I'm going to turn it opposite one side and bring it back into the posterior margin of the vertebral body. So we'll bring it up to right about here, just short of the midline. And we'll insert the spine star ablation device, and it will go the direction. You have a proximal directional indicator here with the arrow, and I will direct toward the opposite side. So we'll start to come out the distal tip of the needle, and right at the distal tip, I'll put a curve on this, and we'll be able to see this come out. And you can already see the curve. Make sure and don't advance the cannula with the curved portion of the needle. And so put a little bit more curve on it, come out. And we can see it's got a pretty decent curve, and to be able to better see that, the direction of the curve, we will come back around to AP. And so by doing this, by aiming this in the region of the ablation zone, the position of the tumor, knowing this either under fluoroscopic observation, but more commonly under cross-sectional evaluation, we'll be able to ablate the correct zone. So you can see the distal tip of the cannula, the ablation device is coming out in the curved fashion, reaching the opposite side. And once we reach the desired area, we can detension this and you'll find a few millimeters distal. We can deploy the bipolar ablation device and ablate away. And this is how the process that you reach all portions of the vertebral body. If you want to bring it back, you can bring it back like this, turn the directional indicator more superiorly, and deploy this as we go up. And we can ablate up, we can ablate down, directional capability. And that is the spine star ablation device.
Excellent.
That performed really well.
Did. Yes.
While you're there, you want to go just put the power curve in while we're there?
Sure thing. So this is kind of different derivation. This is, I'll show the camera here. This is the power curve, and it has a directional capability. It has a bevel here, and it has a directional capability. You can see this little rubber directional indicators. This tells you which direction the curve is going to. So it's pointed up here, and as we twist, we're going to have the curve.
Yeah, it was starting.
Will go toward the directional indicator. So the indicator is pointed this way. The curve is going this way. Again, coincident with the face of the bevel. Here, yes, coincident with the face of the bevel. This exaggerates the steering capability of the needle. So it goes along with the directional indicator. So we'll go ahead and place this within the vertebral body. Let's keep it AP so we can see, and we went up last time. Let's go downward this time. So we place it in, put a little bit of tension on the needle, on the power curve needle. Put a little bit more tension on it, and we'll direct it inferiorly and a little bit across. So have the capability of touching all points of that vertebral body that we want to get to. Detention, pull it back. Let's aim superiorly. A little bit of tension right when it comes out the distal part of the cannula. We can aim it superiorly. I can feel the medullary cancellous bone crunch as I push it through. So we can go up, and we can go across. And this is a very effective steering mechanism. Power curve has an ability to reach all portions of the different parts of the vertebral body. So we are across, very nice, and we can come fairly far all the way across to the other side.
Yeah. We got a curved balloon, sorry, as well.
Yeah, great.
What size is this balloon?
So let's go ahead and take it lateral.
20 millimeter.
Perfect. So this is the Arcadia balloon, and the Arcadia balloon is designed to be used with the power curve. So what we do is we access the various portions of this, and we'll take a lateral shot, and we're right at the anterior margin all the way across. And the Arcadia balloon has the capability of being curved as well. And so this is a righty-tighty, and this deploys the curve. You can see the curve at the distal end of the balloon. This is designed to mimic the curve of the power curve. So these are systems that are designed to be used together. So we'll detension this, we'll remove it, we'll place the Arcadia balloon and take an image under fluoro. We can see.
It's pretty much following the track that you're making with the power curve, right?
Exactly, and it follows the potential, followed the one that I made superiorly. So let's watch this. Let's put a little tension on it as we advance. So we can advance like this, and we can see the markers are starting to foreshorten, which means this is going to the other side, which is exactly what it's intended to do. Foreshorten, and very nice. Now we'll inflate. And notice that the balloon is going to be a larger balloon. It's medial laterally oriented. It's not antero-posteriorly oriented.
Yeah.
This is a high-pressure balloon. It's designed to be blown up in the anterior to middle thirds, and it's designed to reduce exactly the area that you need to reduce. So we have it pretty far and pretty much inflated here. Let's take an AP shot, and we'll see it go medial laterally along the course of the vertebral body. And right in the middle, blow it up just a tad more, because more is always better in anything in life except for taxes. So there we are, right in the middle of the vertebral body. Very nice. Low compliance balloon, medial laterally oriented, blowing it up in the middle to anterior portions of the vertebral body.
Nice.
This is a beautiful result.
And
Ooh, cement.
yeah, go to cement. And normally you have a actual RF machine to help provide RF energy to the cement as it's being delivered to help thicken up the cement. But in this case, we'll just use the handheld device to deliver the cement.
For those who are viewing this remotely, notice that the balloon, it was in the anterior third of the vertebral body, and it was perfectly placed between the medial border of the pedicles bilaterally, so it provides the greatest biomechanical reduction and biomechanical stability when the cement is injected. So it was a perfect targeting.
Let's go back lateral. Okay, we're just going to fill this whole cavity with cement. Again, this is a hydraulic pressure fill device. It has the numbers on the proximal portion so you can see how much PSI as you inject. It's a water-filled system, and we can see approximately the canister filled with cement. And as we inject, we can see the volume that we're injecting on the side. This is as marks the number of cc's that you fill. So we're going to continue to fill and fill the cavity that's left over by the balloon. And filling from front to back. This is fairly viscous cement. Filling the cavity, and then it's going to extend medial lateral and then posteriorly. Pressures we generate are not really more than about 400 psi. And we will stop injecting when we're about a little over halfway back on the vertebral body, about 60% of the way from front to back. There's no reason for that. You can keep injecting, but this will hold almost this whole canister or the whole canister of cement. The optimal amount of fill of this vertebral body is between 15 and 25% of the non-native compressed, non-compressed level. If there's one error that people tend to make, it's not injecting enough cement. Swiss Register said the single modifiable thing that you can do to get greater pain relief and more long-lasting pain relief is inject more cement. So more is better. All right, that's the whole canister of cement.
Nice.
Very nice. Good.
And Doug, from a CC perspective, what is the average volume of a well-injected vertebral body?
So average volume in the lumbar will be between 5 and 8 cc's average volume. So if you're injecting some of the range in lumbar, if you're doing 3 to 4 cc's, it's probably not enough. Thoracic spine will be in the range of 3 to 5 cc's. So just keep in mind that if the cement will harden at a greater rate within the body than it does on the back table or within the canister, and if it's going somewhere you don't like, stop. You can always use another needle, change positions of the needle. Just don't allow extravasation into the canal. Also keep in mind that cement extravasation rates is 20 to 25%, regardless. The U.S. registry that Dr. Schonard has as the principal author on that has a cement extravasation rate of 24%, 0 adverse events from it or significant adverse events. The extravasation rates for some vertebroplasty trials range in the range of 60 to 70%. There's one that's in excess of 80%. No adverse events from this. So extravasation is common, very common. It's typical. Extensive extravasation is not typical, and certainly to have anything like a nerve root injury is unusual to rare. So extravasation, common. Injury from that extravasation, very, very uncommon.
Yeah. I want to pan it over to the tumor ablation of the Medtronic device for osteocool. You can see that how well the ablation zone and a large elliptoid zone there in comparison to where we started. Excellent. Okay. Any questions in the audience or online? Okay, I think we can segue over to the next, if there are any other questions.
Fantastic.
I can't hear anyone over there. Neil, are we good over there, Neil?
Yeah, we're good.
Yeah, we do have one from the audience. Not yet, Ramo. We're just getting the mics rigged up and looking over the chat box.
Perfect. Hey, Doug, so that was awesome, by the way. And by the way, guys, I wasn't doing any vertebral augmentation until 5 years ago, and Doug was like, you gotta take the leap, man. And he's exactly right. And the evidence is growing and getting better and better. And as you're hearing with Neil's Tail of Six registry, we're getting real world data, and we're countering some of the earlier data that really moved the field maybe in a backwards direction for a little while. So I want to ask Doug, because he has exposure to all these different techniques and therapies. When do you choose which one? So is it the degree of compression? Is it the level? Is it the functional outcome of that patient, the age of the patient? I'd love to hear your heuristic for when you use titanium implants, balloon, power curve, et cetera.
So the titanium implants, I use those whenever I think I can get reduction. So reduction is designed in 3 different categories. Number 1, an acute fracture, 6 weeks or less. The second thing is anatomic reasons for reduction. Maybe it has an air-filled or fluid-filled cleft. Maybe it has a visible fracture line. Maybe it has some other reasons for anatomic expectations that you can reduce that fracture. The third is poor bone quality. And people with very poor bone quality, you can get substantial reduction even with an old fracture. And we've seen this a number of different times. So I think if the fracture can be reduced, especially in the thoracolumbar junction, mid-thoracic spine, 6, 7, 8, 7, 8, 9, this is the strength of reduction. And people don't form a Dowger's hump just by one fracture. It's usually 4 or 5 more fractures. And if you can get reduction, it's preferable to do that. So Jan van Meyerheg's surgical free trial said if you can get 3 to 4 degrees of additional reduction, you can take somebody from the basement, put them in terms of the pain, function, and quality of life from the basement to the penthouse. So you can change somebody's performance, pain, function, quality of life, and this is in the surgical free, non-surgical management versus this was balloon kyphoplasty. done, published in 2013. The more you do reduce, the better the patient did. And so if it can be reduced, I reach for a titanium implant. Balloon kyphoplasty is tried and true. It'll provide good control of the cement, a reasonable reduction, significantly more reduction than the vertebroplasty. Sometimes if the fracture doesn't have any loss of height, but just has signal positivity and patients are fairly debilitated, it's very painful, I'll do a vertebroplasty. So I still use all of the techniques that we have. It's just we use them, employ them at a different time, because we now know what we didn't know in the past is that the greater the amount that you reduce the vertebral body, the better the patient will do. The new implants have a significant benefit in terms of short-term pain relief, height restoration, and adjacent level fracture reduction. You can cut the native incidence in half. And so all of these are very important, and they make a difference not only in the current treatment, but in the patient's future.
One more question, Doug. Everything we've watched so far has been transpedicular. Do you ever use peripedicular or enter in the inferior aspect of the vertebral body?
Yeah, absolutely. So we use a peripedicular approach. We use modified inferior plate extrapedicular approach to get around hardware. So these are techniques that I'm not good enough just to use a transpedicular approach. And so within a year of practice, I will probably do 25 to 30 extrapedicular approaches, lots of peripedicular approaches. In fact, the peripedicular for unilateral access, that's my fastball. I just would go farther out than a transpedicular approach. And then transpedicular I use primarily for bilateral titanium implants. That's a good tried and true method there.
Okay, so we have, can you hear me?
Yes.
Okay, sorry. So we have 3 questions from online. The first one was kind of a generic question about cervical augmentation. Maybe you can kind of talk a little bit about some of the new technology as far as doing cervical augmentation first, and then I'll kind of run through the other questions after that.
So I'll take that one first. It's cervical augmentation is just like any other augmentation. Typically it's done anteriorly. You go right next to the larynx, between the larynx and the internal carotid artery. You push your hand down and you move the vascular structures over, and you go directly into the cervical vertebral body. It's quite simple. It's an easy approach. You can do that from C3 or C4 all the way down to C7. Once you get up into the range of C2 and C3, the preferred approach, my preferred approach is transoral. You put a bite block in, it's done under general anesthesia. We saw a patient just Friday, or Thursday rather, that needs one of these, and we put a neck brace on her, and we'll likely do that in the next week or two. So you can also go, there's a described approach to the cervical spine, posterolateral. That's typically done under CT because the vertebral body is just high price real estate back there. And because of the variation in the vertebral body, especially in the elderly, this can become redundant, ectatic. You have to scan first and make sure not to hit the vertebral artery, but the tried and true is anterior approach, just like a cervical discogram. There is no new technology for cervical spine other than what is new that we've shown you here for the thoracic and lumbar spine. These can be applied for the cervical spine with the exception of some of the curved techniques. The arc is too wide for cervical spine. The spine jack implants are not designed to be used in the cervical spine. These are primarily the range of vertebroplasty and balloon kyphoplasty with small balloons.
Okay, so following up on the spine jack, the question is with the spine jack system, how does the impact future surgeries or spine surgery? How does it impact future spine surgeries, and are spine surgeons able to still place pedicle screws, or will this change the approach technique that they'll have to use?
No, you're not going to be able to place a pedicle screw in a vertebral body. Having said that, there's been over 100,000 of these done. I'm not aware of a single scenario with a scenario such as that. I think that's a hypothetical question. Look, if you're going to want to go back and do a pedicle screw, maybe it's the wrong scenario. Just do a vertebroplasty and leave the needle in. There was a great subchapter written in the Comprehensive Guide of Vertebral Augmentation by our own Dr. Schonard that describes leaving the cannulas in place to be able to pull it out. Once you do that, you can actually find that cannula with a K-wire, put it in, and then put the screw in over the K-wire into the cement. But that's probably, if you think you're going to go back and use a pedicle screw and rod augmentation, that's the best technique to use.
All right, so the last question, and I'm going to add to this question a little bit, but I'll give you the question. Until how long after the fracture can kyphoplasty be offered? And maybe you can discuss a little bit about some of the data that's out there on chronic compression fractures. I added that part.
So how long after?
How long after the fracture can kyphoplasty be offered standard? And then I was just wanting to have you comment a little bit about chronic.
Sure. It's also depending on what area of the country you live in as well. In terms of you have to wait a certain amount of time before kyphoplasty can be done in some areas of the country. I think in this area it has to be 6 weeks, where or unless they are having an intractable pain, hospitalized. And so certain indications if it's done before that, but usually conservative therapy has to be done at least for 6 weeks in this region in Washington State.
So one of the things I like to say is if it hurts, treat it. If it doesn't hurt, don't treat it. And there's no limitation for me. There's good data on chronic fractures. There's the not yet published Vertas 5 is a sham trial comparing chronic fracture treatment that are painful chronic fractures versus sham, and provided statistically significant benefit at 1 year for pain and function. So there's actually level 1 data that is impending. This publication is not out yet, but it will be soon.
Also, in terms of, I do get an MRI, and I'm looking for stir sequence changes on that MRI, and seeing if that patient who has a year and a half old fracture, is it still lighting up in that region as an indication for me, and is it painful over that spinous process?
Great.
Thank you, guys. That went well.